Good afternoon, everyone. I am going to present a case of exotropia. Introduction. Intermittent exotropia typically begins before the age of 5 years. The exodeviation becomes manifest during times of visual inattention, fatigue, stress. Parents of affected children often report that the exotropia occurs late in the day. Intermittent exotropia may remain stable, resolve, or progress with time. So here is the case detail. 27-year-old male presented with the complaint of outward deviation of other eye, right eye more than left eye since last 7 years. It was associated with headache. There was no history of diplopia, no history of patching, no history of ocular trauma, no history of any neurological illness. Birth history was within normal. On ocular examination, uncorrected visual acuity was 6 by 9 in right eye and 6 by 6 in left eye. Best corrected was 6 by 6 in both the eyes. Extraocular movements were full and free in all the gazes. Cornea and lens were clear. Fundus examination was within normal. So here is a pre-op 9-gaze photograph of the patient. Corneal light reflex was 25 to 30 degree nasal to the limbus. So sensory examination was done, and sensory examination was 4-dot test and Bagolini striated glasses were done, and they showed that there was right eye suppression. On motor examination, head postures were normal. There was no any head tilt. Hirschberg test, corneal light reflex was between the pupillary margin to nasal limbal border, 25 to 30 degrees. On cover and cover test, on covering left eye, right eye was taking fixation, which was central, steady and maintained. On uncovering left eye, it was again taking fixation, so it indicated that left eye was dominant. So next, prism var cover test was done, and deviation was for near it was 45 prism diopter, and for distance in the primary gaze it was 45 prism diopter. So there was no pattern. So differential diagnosis can be intermittent exotropia, essential exotropia, or sensory exotropia. Since it was adult onset, there was no diplopia and separation. We came to the diagnosis of final diagnosis of intermittent exotropia, which later converted into decompensated and converted into right eye divergent squint, which was Calhoun stage 4. So for treatment, surgery was done, and in right eye, lateral rectus muscle resection was done 9 mm, and medial rectus resection was done 6.5 mm. So here is a 2-week follow-up photograph, 9-gaze photograph. Extraocular movement was full and free. Corneal reflex was central, and there was no improvement or Randor test. So next is the 9-gaze photograph of 2 months follow-up. Here extraocular movement was full and free. Corneal light reflex was central, but patient has gained 400 seconds of arc stereopsis at near. There was no improvement for distance stereopsis. Take home message: always in a patient of any type of squint, always first we do the refractive error. Proper sensory and motor evaluation should be done. Aim of treatment is to achieve stereopsis. Conservative management is done up to Calhoun stage 2, and surgery is done if there is manifest exotropia, that is stage 3 and 4. Thank you.
Just one basic question I'm asking. What is the significance of this 9-gaze photographs? What do it implicates to you, or what do we learn from this? Looking at a 9-gaze photograph for a strabismus is the same thing as reading a visual field for a glaucoma surgeon. So can you tell what all things we infer from that?
From 9-gaze photograph, we can see if we can check if there is any progression, or after surgery if correction is there.
Just not 9-gaze photograph you told, no, pre-operative. When you're seeing, what all things do we see in that? What all inference we get?
We see the deviation.
Because you have shown so many 9-gaze photographs, so you would have understood something and given those. So what are those things we see? Or that photo only speaks a lot of things to you. So what are those points we should see for?
It indicates it is taken in all the 9 gauges. So if it changes, deviation is seen is on all the gauges. If there is any type of restriction, limitation, on subsequent follow-up we can look for that. any improvement is there or not.
You have written there is left eye suppression, correct?
Right eye suppression. Sir, vision.
You attach any significance to that or you ignore that? Okay, go forwards. Go to the Worth 4 dot test picture. There. What is that? Worth 4 dots. Green, you are shown 3 green. Green is in front of left eye
Left eye.
or right eye.
Green is in front of left eye, sir.
It could be right eye also. It depends on which red and green glasses you buy. Okay, green in front. So the red is in front of right eye and green is in front of left eye, and right eye is suppressed.
Yes, sir.
Right.
Red is in front of right eye and green is in front of left eye.
Okay, so right eye is suppressed even though left eye has a peculiar refractive error.
Your right eye had a refractive error,
Yes,
as you
ma'am.
had shown in the previous slide.
Yes,
Plus one sphere, plus one cylinder, he had shown with
180.
180. In the right eye, there was a refractive error.
Yes, ma'am.
So it could be anisometropic amblyopia also.
Yes, sir.
One cylinder is sufficient enough to give rise to
But the visual,
amblyopia.
but the best corrected visual acuity which he is getting is 6/6 with the refraction.
Yes, 6/6, but there is no, there could be a binocular interaction abnormality.
The degree of exotropia, I think he had. What was the degree of exotropia your patient had?
45 prism diopters.
Something is not adding up here to me. You see, if it is just a simple intermittent exotropia which is going on to constant exotropia,
It went to constant exotropia. sir.
now it has gone to constant exotropia. At least for near he will be straight, no matter how much is the distance exotropia is. For near he will be straight. If you force them to look at the near object and ask them to look at it both the eyes, they will straighten out. So 90% of the tropias are only exotropias, intermittent exotropias. Correct?
True.
So it's only very rare that you get truly alternate exotropia.
No.
Anyway, the whole point is to emphasize that you be very careful in assessing. Even now he is not binocular for distance, correct? Which means that it will come back. The squint will come back over a period of time.
In the end, he has mentioned that there was an improvement in the stereopsis in the post-op period. So that was the near stereopsis you were talking.
Nearest.
But the distance which you mentioned, please can you show the slide? It was 16 inches.
400 seconds apart. Good improvement in stereopsis is there, but for distance, you don't
There's
measure the distance stereopsis, do you? You have not measured it.
For distance, sir, for near there is improvement, but for
No, for near there is an improvement of stereopsis.
So the distance is mentioned at 16 inches. The near stereopsis, the distance usually which we take is like 40 centimeters or 50 centimeters.
That's okay. 16 inches
16
is not too
inches
bad.
is
For distance, you measure with the Mentor's distance stereoptor.
the random, even the distance random which we do.
See, what happens is these things, for distance, there is no fusion, and they gradually break up. And few near also they break up, even though you have operated.
So even the FD2 test which we do is at 3 meters. I think you should correct the distance here. It might not be 16 inches. It might be 25 centimeters or 40 centimeters. The distance, that is a typographical error, I guess. So that needs to be corrected. And yes, as sir has emphasized, that exotropias are notorious sometimes for an exodrift. There might be a recurrence, especially in these type of cases where there is a suppression, a gross suppression. The good thing is that your patient has gained some stereopsis now. Let's see, I think he should be advised some exercises in the post-op period also to keep them aligned.
Yes, ma'am. Okay.
Okay, thank you.